Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in. Today we're going to be discussing soft tissue injuries. Afterwards, we'll have some multiple choice questions for review. But let's get started with our lecture brought to you by Carly.
We'll start by talking about the incidence of soft tissue injuries. So how often are we seeing these injuries, specifically those that are brought into the ER? So there's about 6.5 million visits every year in the United States to the ER for open wounds. And there's about 5 million visits each year to the ER for closed wounds. So open wounds being those that penetrate the skin or damage that skin barrier, and closed wounds being those that do not penetrate the skin. When we have death due to soft tissue related injuries, it's usually because of hemorrhage, so a massive loss of blood or infection. Now, when we talk about the severity of soft tissue injuries, they can of course range from minor to severe. We know that. We can get everything from a paper cut or a small bruise all the way to deep lacerations all the way into our muscle tissue. So that means they can also be barely visible to extremely grotesque. But it's important to understand that the visibility of a soft tissue injury does not necessarily correlate to the severity of an injury, right? We can have some extreme internal damage that has not yet made an appearance on the surface for some of those closed injuries. However, soft tissue injuries can be very visually distracting to the EMT. So they can draw our attention in really quickly. They can look pretty, gruesome. So it's really important that, first of all, we suppress our reactions while treating the patient. We don't want to overreact. We don't want to alarm the patient. But we also don't want to get blinders on. We don't want to be so involved in this soft tissue injury that we are missing the, deformed femur or the spinal injury or a patient's change in mentation, right? So we want to address these injuries, but stay focused on the entire patient. So first, we're going to start by talking about the function of the skin. The skin is this protective layer that of course, is a physical barrier for infection. It also is a huge part of thermoregulation. It protects our internal anatomy. So it's a really important organ and a really important component of the severity of the injury. So it's the largest organ in the body, and it can vary in thickness depending on age and location. So what does that mean? The location, so where on the body are we talking about? Are we talking about the scalp, back, soles of the feet, which are all tend to be pretty thick in most of us? The skin layer is pretty thick. Or are we talking about eyelids, lips, ears, which tend to be a little bit more thin? And we see changes based on age. So as we get older, the fatty layer, that subcutaneous layer, can kind of thin out, and it means our skin is much more susceptible to damage. So as we're looking at the injury pattern, we do have to look at where on the body did it occur, how old is our patient, and that's going to play a role in how severe the injury is. The skin, as I mentioned before, keeps harmful organisms out. And really, when we get that break in the skin, we can get organisms that enter the bloodstream, and that's what causes infection. So the skin keeps blood and fluids inside the body. It keeps outside bacteria and organisms out. It helps regulate temperature. The nerves in our skin sense the need for vasodilation or vasoconstriction. So are the blood vessels kind of opening up or closing? Closing would be a way to maintain heat, shunt some blood back to the core. Vasodilation when the body's hot, so we can offload some of that heat. When we're talking about the layers of the skin, we have the epidermis, and that's the tough external layer. It's watertight, just the way the cells in the skin overlap one another, but they are constantly worn away. So we have that uppermost layer of dead skin cells. They're often worn away. The new cells are regenerating underneath, and they kind of move to the top as that top layer is sloughed off. It also contains the pigment of the skin, or the melanin, where of course we get our skin color. Then we have the dermis, which lies just below the epidermis. That's where hair follicles, sweat glands, and sebaceous glands all sit. Sweat glands help cool the body. Sebaceous glands produce oil to help keep the skin waterproof and to keep it soft. And then, of course, hair follicles we know are located in that dermis layer. Then we have the subcutaneous layer. The subcutaneous layer actually attaches the dermis to the muscles and bones. So it's a fatty layer and it helps with temperature regulation. So kind of keeping the body from losing massive amounts of heat, and then attaching skin to underlying structures and tissues. So now we're going to talk about the process of wound healing. And when we refer to the pathophysiology of wound healing, there's 4 main stages that we're going to go through. The first is hemostasis. The second would be the inflammation phase. The third would be epithelialization. And the fourth is collagen synthesis. So when we refer to hemostasis, that's the process of just stopping the bleeding. The natural processes involved in stopping bleeding, so the way the body does it is primarily through vasoconstriction and then clotting or coagulation. So the vessels around that wound constrict, limit blood flow to the area, and then we get platelets and other clotting factors that are triggered, and they start to form a clot in the area so that we don't lose more blood. In a healthy patient with typically a non-arterial bleed, this should occur pretty quickly, that hemostasis process, the stopping of the bleeding. The body is triggered pretty quickly to step into action to limit blood loss. Following the hemostasis, so once the bleeding stops, we now enter into an inflammatory phase. So the vessels then dilate to allow antibodies, white blood cells, and other factors to surround the injury. And of course, the goal would be to kill any infectious organism that has entered the body. This does trigger a histamine release. So that's kind of what allows the vessels to dilate, blood flow increases to the area, and it floods that area with antibodies and white blood cells. So we get some swelling because we have extra fluid being delivered in order to deliver those extra cells and nutrients. So the result is the removal of waste and foreign material from the area to initiate the healing process, or at least that's the goal of the inflammatory phase. Now, this is a natural part of healing, and some inflammation is normal and okay, but it does need to be monitored to ensure the injury doesn't become infected. So too much inflammation can cause infection if it prevents the rest of the healing process to occur. Epithelialization. So this is the process by which epithelial cells actually cover an injury. So this is when we're starting to get that new tissue to develop. They do this by multiplying from the stratum germinative layer to form a protective layer over the wound. So it's kind of the migration and formation of new cells to cover the wound. And it's a really important step in reforming that physical barrier to block our bloodstream from the outside environment. So this process is a really important step from going from an open wound to a closed wound and then allowing that tissue to heal. Then we have neovascularization, which is neo meaning new, vasculature meaning vessels. So the formation of new blood vessels where new capillaries kind of form and branch off of existing ones. So this allows for the delivery of oxygen and nutrients to the site and the removal of waste. So this can take weeks to complete. This isn't an overnight process. This is where we get, kind of that final healing stage. And rather than kind of temporary fixes being put in place, this is a more permanent step to heal and then supply that new tissue with blood indefinitely. Then we have that collagen synthesis. Collagen is a protein that forms a large part of the extracellular matrix, meaning that it is providing structure and then some elements of function to the tissue. So the formation of collagen is going to help restore the physical strength and structure to the healing wound tissue. So we have a physical barrier, we have some blood coming up, and then we have structure being added to those cells so that we have new skin that at the very least closely resembles the previous skin. And of course, depending on the severity of the injury, the scar tissue is going to form a little bit differently, but the goal would be to restore that previously existing skin tissue. Now we'll talk about some factors that can alter the wound healing process. So what can interfere and cause a wound to heal incorrectly? Well, first we have anatomic factors. So that includes areas of the body that are constantly moved and they just heal more slowly. So we think about skin over a joint. It's really hard, like in the fingers, we know that it's really hard to keep a wound on the fingers, like a knuckle, allow that skin to heal, because every time we bend the finger, it puts tension on it and it can break down some of those new structures that have formed. It also, like places like our hands where we're washing them, they're exposed to water, they're just exposed more in general. They don't always provide the quickest healing. Concurrent drug use. So there's certain drugs that can predispose a patient to slow wound healing time. Corticosteroids, non-steroidal anti-inflammatory drugs. So we talked about the process including inflammation and that being necessary. So if that's being kind of held back, then it can slow down the healing process if we're not getting all of those white blood cells and such to the healing site or to the wound site. Penicillin, anticoagulants, anti-neoplastic agents. So all these different medications are, of course, helpful in some scenarios, but they do slow down the body's natural healing process. And so we can get a delay in our wound healing. There's also some medical conditions and diseases that can interfere. Advanced age, alcoholism, acute uremia, diabetes, hypoxia, severe anemia, peripheral vascular disease, malnutrition, advanced cancer, hepatic failure, and cardiovascular disease. They can all inhibit wound healing. And of course, each is going to be for a slightly different reason. So we know that with age, metabolic processes slow down. Severe alcoholism, we have kind of a decreased immune response. Diabetes, we often have poor blood flow to begin with, so that neovascularization stage can be inhibited. Hypoxia, so not enough oxygen. Of course, poor oxygen means poor perfusion. That doesn't help with wound healing. So all of these can play a role in the wound healing process. There's also some really high-risk wounds. Human and animal bites have a high risk of infection. Really, any puncture wound has a high risk of infection, but specifically with bites, there's a lot of bacteria in mouths. And so you have a lot of bacteria, you have that joined with a puncture wound, and so you get a really high risk of infection. Really, any wound that involves a foreign body or organic matter being embedded into the wound is a high-risk wound. So injection wounds, crush wounds, wounds with devitalized tissue or almost like necrotic tissue, those in patients who are immunocompromised. So then that's going to alter their healing process. Patients with poor peripheral perfusion are also at high risk. So anytime we're not getting good blood flow, we have tissue death, we have injuries that are hard to heal, where tissue is just completely broken down or hard to clean. All of those create high-risk wounds. We also have instances of abnormal scar formation that can cause long-term issues for a patient. So if a wound penetrates the dermis really deep, you have a higher risk of abnormal healing, of course, because you have more tissues involved, more steps involved. So if the reticular dermis or that innermost layer of skin is involved, you have a high risk of this abnormal scar formation. It's where blood vessels and supportive connective tissue are located, and really any condition that increases the risk of systemic inflammation. So anytime the body has a higher risk of kind of a whole body wide, almost like histamine or inflammatory response, you get a higher risk of these funky scars. The two examples that we're going to talk about are keloid and hypertrophic scars. So keloid scars are raised and firm, and they occur if there's excess collagen during healing. The problem with these is that they can be itchy and painful and actually restrict the range of motion depending on the scar. So especially if the scar is forming over a joint or an area with a high range of motion, that thick scar tissue can really interfere with movement. It doesn't have the same elasticity that our normal skin would have. The other problem is that they can actually spread beyond the injury site and they don't improve over time. So they take up even more space than was actually damaged, which again restricts range of motion that much more. Hypertrophic scars are really similar to keloid scars. You get an overproduction of collagen, you get a firm and raised scar. They can also be itchy and painful. The only difference is that they don't spread beyond the borders of injury, and they do have the possibility of improving over time. So you can get a reduction in some of that scar tissue over time. So now we're going to talk about some wounds that require closure. So when do staples or stitches or some sort of glue need to be introduced to the wound in order to heal properly? A lot of times cosmetic regions will be closed. And that's because there's a risk of kind of an abnormal scar forming. And while some of us might not care if we have an abnormal scar on our hand or our leg, we might not want a large scar on our mouth or head or nose or something like that. There's some psychological implications to some of those cosmetic regions. Gaping wounds, so wounds that aren't going to necessarily come together naturally, often need to be healed. So in this picture, we see an example. This is most likely from a knee surgery. That's a large incision, and so it needs to be brought together. It's not just going to heal on its own, well, at least. Wounds over tension lines or areas. So again, like we think of the scalp, so static tension where there's limited movement, there's just constant tension, or dynamic tension, so areas that lie over muscle. So something that's going to, every time, if we think about the bicep, every time it's flexed, there's some dynamic tension that's put on it and it's at risk of opening again. And so sometimes those wounds do need to be reclosed with something beyond just natural body processes. Degloving injuries also require closure, and sometimes much more than just closure, sometimes irrigation, debridement, or so removal of debris and dead tissue, and sometimes surgery. Ring injuries, so these, when a ring gets caught, we can get a degloving injury, but we also can get an amputation, we can get a burn. So ring injuries also require some sort of advanced level of care. And then skin tearing, and a lot of times we see this in our older patients. Their tissue becomes really fragile, and they can get skin tears, and sometimes this is just steri strips that are used to kind of keep the injury closed. Sometimes it's a lot more extensive, and of course more than just our geriatric population can get skin tears, but that's just an area of the population that tends to experience those kinds of injuries at a higher rate. So now we'll talk about some open injuries. Open injuries can be caused by blunt or penetrating trauma, and the depth of the injury might not be obvious, especially with some of those puncture wounds. So it's important that we ask questions regarding the instrument that caused the injury. So was this, a 12-inch steak knife? Was this a scalpel? Was this a pen? What caused this injury? And then we need to know that the extent of bleeding or the injury might not be visible or immediately obvious. So we can get a lot of internal bleeding even with an open wound. So you need to consider the potential for underlying injuries. So what structures are located below the injury? Is it possible that we're going to have arterial damage? Are there important, vital organs that can be bleeding out that might need immediate surgery or attention? So just know that just because an injury doesn't look bad doesn't mean that it is not bad. The types of wounds we're going to go over are avulsions, bite wounds, lacerations, and puncture wounds. So an avulsion is an injury that results from a shearing force or forces that are applied in opposing directions, and it causes the separation of tissues from the base. So often this shearing force causes a flap of tissue. And so the amount of bleeding is really dependent upon the depth of the injury. So did we just get kind of a flap of the top epidermis layer, maybe some of the dermis, or did we go all the way down to that subcutaneous layer and we have a really deep injury, we have fatty tissue involved? That's of course not good. A lot of times these injuries heal by second intention. So what does a second intention or secondary intention mean? It means it's a more extensive process that's common in deeper wounds where there's some tissue loss. So that means that a lot more cells have to move to that injury site. This granulation tissue has to form. It's kind of this temporary tissue that forms to fill in gaps where tissue's lost. And then scar tissue can form. So it's not just kind of an easy process of those tissues resealing, kind of coming together, but there's actually a lot of new growth due to lost tissue. Some special assessment findings for avulsions may include partial or complete loss of skin tissue. So if the skin flap is still attached, you need to care for it. So it can be cleaned and it potentially returned to the anatomical position to heal. If it's pinched and blood flow is decreased, that tissue can die. So it's important that we pay attention to the position it's in and try to make sure it's also still getting blood flow. And then the hospital can decide whether that can be reattached or if some other process is going to have to take place. We do have to realize that avulsions, because of the amount of tissue that's exposed, can be very easily contaminated. So we can follow your local protocols on this, but you can, in a lot of cases, gently irrigate it with a sterile saline solution. And you might get some drainage, serosanguinous drainage, and that's a leakage of blood and serum from a wound. So it is usually going to be kind of a thin pinkish color, and so you might see that coming off the wound, which is normal. But just know with these injuries, these are going to be pretty distracting injuries because, again, there's a lot of exposed tissue. So this is where we have to be really careful, take care of the wound, but make sure you're also addressing the whole piece. Some special management considerations, of course, control hemorrhage. You can gently ice the area. We're just minimizing pain and swelling and preserving some of that tissue that might not have a good blood supply any longer because it's been torn away from its blood supply. Don't place ice directly on the wound, but you can, wrap that ice up and just keep that area cool. Again, follow all your local protocols on that. Emergent care often involves controlling the bleeding, light irrigation, holding the flap in place, and then using a dry, sterile dressing. So cover it up and then get that patient to the hospital, right? So a lot of this care for an avulsion injury can be done en route. You may irrigate it on scene, but honestly, if you place, like a Chuck's pad underneath, you can do some irrigation in the back of the ambulance and get that patient to the hospital. That's where they need to be. Sometimes in the hospital, they might have to do surgery, skin grafts, special kinds of bandaging. We just don't have the ability to do that in the field. So we really just need to control their bleeding, get them to the hospital. An amputation, we're not going to go in depth about, but it is basically a completely avulsed body part. So if we lose a finger, an arm, leg, penis, ear, those are just, of course, examples of things that are appendages that can more easily be amputated. That's when often we get some sort of shearing force, but it takes that whole appendage. So now we'll go into bite wounds. So there's different types, of course. We can have animal bites. Dogs can cause different types of soft tissue injuries, with elderly and young kids being the most susceptible to infection just because they don't usually have as strong of an immune system. Cat bites, as opposed to dog bites, are usually more infectious due to the Pasteurella multocida bacteria. And that's just a bacteria that exists in the mouth and throat of cats and can easily cause infection in tissue. So it can cause pain, tenderness, swelling. But basically these puncture wounds, they can be more than just punctures, of course, but they can go pretty deep and introduce a lot of bacteria into our bloodstream. We can also have human bite wounds. Again, that can cause different types of soft tissue injuries. A lot of times that will occur in the hand, and they often result in a secondary infection due to a delay in treatment. So people don't always get human bite wounds addressed as soon, and so we can get an infection from that. And again, human mouths are also not clean. There's a variety of bacteria. So there's all different sorts of infections that can be introduced that way. We can also have spider bites, different insect bites. So spider bites being one of them. In the United States, the brown recluse and black widow are the two most dangerous species of spiders, with black widow being considered the most lethal. We can have tick bites, and we'll go in depth a little bit over the management of some of these bites, but there's also scorpion stings. Typically, we find this in the southwestern United States. You have it's usually painful, but not typically lethal. In rare cases, a patient might experience a systemic reaction. So they might get paresthesia. So that's an alternation in sensation throughout their body, difficulty swallowing, and blurred vision. Hymenoptera species, so fire ants, wasps, hornets, bees. There's estimated that there's over 1 million stings each year. Only about 3% of these stings or bites require treatment for anaphylaxis, but it's still important that if you have a patient who's been stung by a bee, bitten by a wasp, bitten by fire ants, you ask if they're allergic, if they carry an EpiPen, and you're monitoring for some sort of anaphylactic reaction. The reason a patient would experience pain from something like this is because of a protein in the venom called melatonin. So that's just an interesting bit of information, but about 25% of patients will experience a local reaction like swelling or skin irritation. And again, usually only 3% of these have a full-blown anaphylactic reaction. So with bite wounds, we do run the risk of transmitting rabies or having rabies transmitted to us, which is a rare but serious complication, most common in animal bites. We don't see it as much in dogs just because of the huge push for rabies vaccinations in dogs, but we can see it in dogs, squirrels, bats, foxes, skunks, and raccoon bites. It's not always immediately apparent that the animal is rabid. So it's really important that we find out what bit the patient and we pass that information along to the hospital and make a report of it so that if the patient needs to be treated for rabies or vaccinated against rabies, that happens sooner rather than later. A rabies vaccination doesn't occur until that bite has taken place and there's a concern for rabies. That information needs to be made clear to the hospital staff so that they can initiate the rabies vaccination. And then, of course, we want to transport quickly. We want to get them to the hospital quickly, especially if we don't know whether or not the animal's been vaccinated against rabies. When we're treating these patients, we're of course controlling the bleeding. We can splint the affected area. The big thing is to limit range of motion to try to prevent the spread of venom or bacteria into the bloodstream, and then initiate transport to the hospital and make a report. When we're talking about some bite wounds, some special assessment findings for animal bites, we need to know the time since the bite and the type of animal. And then for human bites, the location. So where did the patient get bit? And is there already the presence of infection? Does the tissue already look infected because there may have been a delay in seeking treatment? When we're talking about insects, so with black widows, the reason they can be so lethal is because the spider can release a neurotoxin that may cause respiratory depression. It's not guaranteed, it doesn't happen in every case, but it's definitely possible, so it's something that needs to be monitored. The brown recluse spider, you might see flu-like symptoms in hours following the bite. The bite location can become painful, show signs of skin breakdown for 12 to 36 hours after the bite. So we can get some pretty severe necrosis of tissue in a brown recluse bite, and that's something that we need to monitor for, especially if it's, maybe the bite happened a few days ago, the tissue starting to die, look infected, look just kind of icky. So see if the patient knows what they've been bitten by. The patients who get bit by an insect or a spider might not always know what they've been bitten by. So it's important to recognize some of those symptoms. With fire ants, it's the most likely to cause infection of the Hymenoptera species, simply because they usually form little pustules, and if they get itchy, and so if those little pustules are itchy and the patient scratches them, once they're broken, there's a higher risk of infection because now we have an open wound, it's itchy, they're introducing bacteria from their fingers and the surrounding environment. So with those, bee and wasp stings, we might experience an anaphylactic reaction. With the fire ants, we're most likely looking at an infection. When we talk about tick bites, so you need to know your area pretty well. So where was this patient and what kind of organisms are in your environment? So tick bites are most likely to occur in the outdoors, specifically in woodsy areas. And a lot of times you'll see a tick still attached to the skin. The way the tick bites is actually usually it's whole. They have little heads and they kind of corkscrew their heads into the skin. So you can often still see them attached, and they can cause something called Lyme disease, show signs of like a febrile illness. So the Lyme disease begins with flu-like symptoms, but it can progress to joint inflammation and then neurological and cardiac disorders. So it's a serious condition. So it's important to identify the tick and ask the patient where they've been, because they might not discover that they've been bitten by a tick until well after they're indoors or away from the area that introduced the tick. So ask them where they've been in the last couple days. With ticks, you can see a Rocky Mountain spotted fever as well as Lyme disease, which is an illness that presents with headache, muscle aches, and fever. Big thing with tick bites is to just prevent them. So knowing that ticks are common, wearing, long sleeves, long pants, trying to prevent those ticks. So when we're talking about management, now we're going beyond assessment and we're talking about management. When we're looking at animal bites, scene safety is the biggest thing. So is the animal secured? We don't want to walk on scene where there's still that aggressive animal out. Once that animal is secured, we want to control the bleeding, clean the wound, and then report the type of animal bite. So figure out what happened, control the bleeding, get the patient to the hospital, and make a thorough report of what the patient documents. With a human bite, we're of course wanting to know who caused the bite, why were they biting you, include all that in your report. If you're suspecting abuse, neglect, of course, have mandatory reporting. There's very few instances where we're going to be arriving on scene to a human bite and there's not some sort of abuse or neglect or violence involved. So make sure you're doing really thorough documentation, passing that along to the hospital, but also other necessary, so making a report with law enforcement, your supervisors. That's something that usually requires more documentation. When we're talking about managing spider bites, if the patient was bitten by a brown recluse or a black widow, you want to immobilize the affected extremity and transport to the hospital. So for the same reason we talked about with some of the animal bites, we want to limit range of motion. We want to try to limit that venom spreading or that bacteria spreading. So if we can immobilize it, sometimes we can cut down on the spread of that infectious agent or toxic agent. With fire ants, of course, remove the victim and the crew from the ant mounds. So if the patient's still sitting in the ant mounds, we're not going to sit in there with them and treat them. We want to get them out. We want to brush off all the ants. We want to make sure we don't have any ants on us, and then just really provide them supportive care and get them to the hospital. So when we talk about tick bites, inspect for ticks if you're suspicious. So if a patient has some symptoms of Lyme disease or that Rocky Mountain spotted fever, they've been in a woodsy area, you want to look at their scalp, look at their ears, their armpits, sometimes in the groin, areas where patients might not immediately notice something, their back. And you can pull the tick straight out of the skin with tweezers, but again, it's important to remove the tick completely, not just the body. The heads can become detached. So there's different tools and devices that can be used, but just know the proper way as far as your protocols go for removing ticks from a patient so that you do it correctly. You also don't want to crush the tick when removing. Their bodies often fill with blood, so we don't want to crush the tick. And if they're ill, if they're showing symptoms of, sometimes you might see a bullseye rash associated with the tick bite and Lyme disease, you want to get that patient to the hospital, let them know that you're suspecting a tick bite just based on the history, and just provide them that supportive care in the field. Okay, we're going to move away from bites, and now we'll talk about lacerations. So lacerations are cuts or incisions. Usually a cut or an incision is going to have a smooth, clean edge, kind of like what you see in the picture. A tear can have rough or jagged edges, but a laceration, depending on the depth, can cause arterial, venous, or capillary bleeding, or all three. There's, of course, a variety of causes that can vary the wound severity. They can cause arterial, venous, or capillary bleeding, like I mentioned before. So You have to consider injury to tissues beneath the laceration, just like with any penetrating wound. So is there tendon or ligament involvement? Is there organ or bone involvement? If damage is really extensive, you can have a lot of bleeding. You may see shock. So it's important to really closely monitor the patient's vitals and control bleeding. Monitor their mentation as well. If a patient's going into shock, a lot of times you're going to see changes in mentation. So if the patient has massive bleeding, you're not able to control it, or maybe it's internal bleeding that you're not seeing, monitor that patient's mentation, their skin signs, and their oxygen saturation. Keep an eye on those patients. They can decompensate very quickly. It's helpful to find the object to determine the potential depth of the injury, and then either take the object with you or take a photo of it so that the doctor can see the size and make some guesstimations on the injury depth. So we're looking for an inverse cone-shaped injury pattern. So something that's a little wide on top, narrowed down at the bottom. For a lot of those injuries, of course, that's not always the pattern that occurs, but from the point of entrance, how far could, if we're dealing with a blade, how far could it reach in every direction? So do we think the liver is involved, or the spleen is involved, or was it not a very long blade and we don't think it went much past the subcutaneous layer? Those are things we're looking at. And then we have to assume that there might be a loss of tissue function and infection that can occur with a delay in treatment. So when did the injury occur? What caused the injury? Was it a brand new scalpel, or was it, rusty shears that have been sitting outside for, 3 years? It's important, of course, to control bleeding. Always important to control bleeding. If the patient has arterial bleeding, you may need a tourniquet. So we may need to just cut off all blood supply to that area. If you've applied dressings and you have the bleeding under control, of course, do not remove any of those dressings and do not remove tourniquets. Make note of the depth and the object responsible for the wound, and then pass that information along to the hospital. All right, with penetrating and puncture wounds, those are objects that go through the skin, of course. Knives, bullets, branches, tools, shrapnel, even bites. So penetrating usually implies that there's an entry and an exit wound, while puncture implies that there's usually just an entry wound. So penetrating might be like a bullet that has an entry and exit wound. Puncture might be like a stab wound into the abdomen that didn't go all the way through. Again, we want to consider the depth and location of the wound and what kind of tissue was involved to determine the severity of the damage. So again, it can appear minimal, but damage and bleeding beneath the surface might be extensive and even life-threatening. There can also be a lot of bacteria introduced, and it's hard to irrigate these wounds. We also have to consider the type of object and the speed at which it's traveling. So was this a knife that couldn't travel very fast, or was it a bullet? Was the bullet from a rifle or a handgun? We know that rifles can have a lot more power behind them, can cause really extensive wounds. Also, how far away was this person, shot at point blank, or were they shot from 100 yards away? So, and there's obviously a whole range in between. So what caused the injury? How far away? How fast was the object moving? And what was the object? Penetrating and puncture wounds can get infections easily, like I mentioned, because the wounds are difficult to assess, even in a hospital setting, and they're difficult to clean. So they're difficult to clean on the front end. They're difficult to keep clean. So just try to do your best to assess, but ultimately the hospital is going to do another assessment on those patients. If you see an entry wound, and if you're thinking, wow, it's possible that this came out the other end, take a look. Look at the other side of the patient. Look for an exit wound somewhere, so that you can make sure you're controlling bleeding and addressing all aspects of the wound. And of course, the velocity, which has to do with both speed and direction of the object, are going to play a huge role. So was the person shot, through the shoulder and it just went through the shoulder, or were they shot through the shoulder and it came out their hip or abdomen? So now we have a lot of vital organs potentially affected in between. Objects that penetrate the skin might not come back out on their own. So we can have an impaled object, an object that's just stuck in the body. And they have the potential to cause more injuries, right? So they can, as the patient moves around, they can cause more damage. The goal with an impaled object is to just stabilize the object and transport that patient as you see them. You might need depending on the patient might be stuck, the object might be too big to transport them, so you might need to alter or cut the object, but try to minimize that, because if you're manipulating the object, you can cause more damage to the patient. So the goal is to just stabilize it and get them to the hospital, support their ABCs, get them to the hospital. Gauze, tape, whatever you have to try to stabilize that wound. And yeah, don't try to shorten them. If it's something in the eye, make sure you stabilize it and cover both eyes so that the patient's not looking around and causing more ocular damage. You want to be alert for edema or swelling, and you can potentially use some ice to help control swelling. The tetanus antitoxin, so tetanus shot or vaccination at the hospital. Tetanus is caused by the Clostridium tetani bacteria, which is typically found in soil, and it can cause painful muscle spasms that interfere with breathing and lead to death. So you hear lockjaw, that's associated with tetanus, and it's actually not usually a rusty object, but rusty objects are usually found in the soil where that bacteria is located. So that's why we associate tetanus with something that's rusty. But the antitoxin can be administered to avoid these complications. So a lot of times we're supposed to stay up to date on our tetanus shots, but if you talk to a lot of patients, they have no idea when their last tetanus vaccination occurred, and so they're probably going to get one of those at the hospital if they have some sort of puncture wound. When we're managing these patients, we're trying to prevent infection. So thorough wound cleaning, possible debridement may be necessary. We're not going to do a lot of that in the field, but we can do some irrigation and then get them to the hospital so that that puncture wound can be appropriately cared for. So if you can inspect the wound at all, just get a picture maybe before you put gauze on it. If it's not just hemorrhaging and it's not an arterial bleed, you can kind of get a look at the extent of the injury, so you can at least pass that along to the hospital and let them know what they're dealing with before you put some gauze on it and try to package it up. And then of course, we're always providing supportive care, right? Monitoring airway, breathing, and circulation with all of our patients. We'll briefly mention evisceration, which is when internal organs are protruding out of the body through an opening in the skin. Usually this has to do with some sort of abdominal organ, and you may not see visible bleeding. It can protrude through a very small hole in the abdominal wall, or you might have a wide open cut. There can be, of course, internal and external bleeding, significant bleeding. Organs can also dry out. We have a risk of infection. It's visibly disturbing, so you want to cover that patient with sterile gauze, usually moist gauze, and get that patient to the hospital. We're not pushing anything back in. We're just trying to keep those organs moist. So some general treatments with these patients: if you have a minor soft tissue injury, nothing life-threatening, you're treating their ABCs, provide bandaging and splinting as needed, and then make an appropriate transport decision. So can this person go to, a local hospital? Do they need to go to a level 1 trauma center? Probably not if it's a minor soft tissue injury. So just get them to the level of care that can adequately address their injury. With moderate soft tissue injuries, maybe it's not life-threatening right now, but it could become life-threatening. So again, we're still treating ABCs and we're reassessing every 5 minutes. Bandage and splint, but you need to keep checking for bleeding. So maybe you have that bleeding controlled, you're talking to the patient, and you look down and now that gauze is saturated and it's dripping. Well, now we need to apply more pressure, more gauze, and we need to get that bleeding back under control. We're also trying to protect that patient from contamination. So keep it covered, try not to introduce any more bacteria to the wound, and make an appropriate transport decision. Maybe this patient needs to go to a higher level of care to address that wound. They're going to need stitches. Maybe they're going to need surgery or some sort of debridement to control their wound. With some of those severe soft tissue injuries, these might be life-threatening injuries. So still, we're treating ABCs. Don't be distracted by the injury. But in those ABCs, that means controlling bleeding. So cover an ugly wound, stay focused on ABCs, but expect complications with their ABCs. If they're hemorrhaging, their circulation is going to be compromised, which means that we might see an increase in their respiratory rate. We're going to start to get some of those shock symptoms. So keep reassessing your patient, get that bleeding under control, get your circulation under control, bandage and splint as needed, and just check all, if you put a tourniquet on, make sure that that tourniquet is still holding and you don't need to add a second tourniquet. If you have a pressure dressing on, make sure that that pressure is holding and it's not bleeding again. And then make an appropriate transport decision. Does this person need an air ambulance up to a level 1 trauma center, or can your local hospital take care of it? So know the hospitals in your area, their capabilities, and then when you might need to initiate more rapid transport or extensive transport. Some new treatments that are available, one is the IT clamp, and it can be used to close an open wound to limit bleeding. A lot of these new treatments are introduced by the military for serious combat wounds and aren't actually seen a lot of times in the civilian setting. That link will take you to a video if you're interested in looking at the IT clamp. Hemostatic agents, you might see them in a clotting powder. There's different examples of that. That can stop bleeding. With the clotting powders, though, they can create high temperatures. They can be really difficult to clean out those powders and can actually cause clots further down in vessels if those powders get carried down the bloodstream. So a lot of times we see a gauze that's impregnated with a hemostatic agent, and those hemostatic agents just promote clotting factors to get to the area. They can also sometimes promote vasoconstriction. So sometimes just packing those wounds in general, even if it doesn't have a hemostatic agent, can help control bleeding, but that agent helps initiate that hemostasis a little bit quicker. Tactical trauma tourniquets, so they're used by the military and easy to apply, and you can apply them yourself if you're injured. So there's different types of tourniquets. There's kind of the traditional tourniquet we see, but the military does have like junctional tourniquets, so tourniquets that would be useful if perhaps the leg was amputated away from the torso, where you couldn't apply a traditional tourniquet. You can apply them around the waist, and they can be used on the inguinal artery, for example, and stop the patient from hemorrhaging from that amputation. So there's lots of different treatments available. You might not have access to all of them, but there are things to be looking out. Thank you for joining us for this EMT class lesson, and we hope to see you next time.
All right, we're going to do some review questions on soft tissue injuries. Question 1. When treating a closed soft tissue injury, you can apply the mnemonic RICES, which stands for, potential answers are rest, ice, compression, elevation, splinting; rest, immobilization, constriction, elevation, stabilization; rest, ice, compression, elevation, stabilization; or rest, immobilization, compression, elevation, splinting. Correct answer is rest, ice, compression, elevation, and splinting. The mnemonic RICES is commonly used in medicine, and it stands for rest, ice, compression, elevation, and splinting. Next question. You are called to the scene of a rock climbing wall. Your patient is a 22-year-old female with trauma to her lower leg. The injury appears to be a large flap of skin and tissue hanging off her leg that occurred when her foot slipped while climbing. This injury can be described as, answers are an avulsion, a laceration, an abrasion, or a contusion. Correct answer is an avulsion. An avulsion is most commonly described as a flap of skin or tissue still attached to the body. A contusion is a closed wound like a bruise. An abrasion is usually superficial and appears as a scrape across the skin. A laceration is a cut that extends through multiple layers of skin and subcutaneous tissue. Question 3. You conduct a detailed physical exam while transporting a patient to the emergency department. There is a section of the abdomen that is distended and rigid. No bleeding is present anywhere else on the body. You decide this is a serious discovery you may have missed during your rapid trauma assessment. What does this finding most likely indicate? Answers are internal bleeding, broken capillaries, penetrating trauma, or stroke. Correct answer, internal bleeding. During physical exams, you are looking for abnormalities on your patient that may indicate complications either inside or outside the body. In the abdominal region, if there are any rigid and or distended areas, this could be an indication of internal bleeding or blood pooling. Next question. You are treating a patient that amputated a finger while using a circular saw. How should you package the amputated part? Answers are: place the finger on ice, place the finger in a cup of milk and place on ice, sterilize the finger, place it in a bag and place the bag on ice, or wrap the finger in an occlusive dressing and put it on ice. Correct answer: wrap the finger in an occlusive dressing and put it on ice. Putting the finger directly onto the ice could destroy more tissue, making reattachment impossible. Without excessive handling of the finger, wrap it in a sterile dressing and keep it cold. Next question. All of the following are characteristics of a laceration injury, except potential answers: bleeding can be severe, caused by a forceful impact with a sharp object, a superficial and painful injury, or a break in the skin of varying depth. Correct answer: a superficial and painful injury. Laceration injuries are typically not superficial, and they can range in pain from mild to severe. Next question. Your 22-year-old patient was kicked in the eye during a fight. You notice that the injured eye has a collection of blood in front of the pupil and iris. You most likely suspect. Answers are: retinal fracture, hyphemia, corneal detachment, or raccoon eyes. Correct answer: hyphemia. When blood collects in the anterior chamber due to trauma, you have what is known as hyphemia. This condition must be evaluated quickly, or the patient may lose their eye. Next question. You are treating a 24-year-old male who was found buried up to his waist by rocks and dirt. He is conscious and alert, but it's suspected that he was there for at least 4 hours before anyone discovered him. What is your greatest concern before he is unburied? Answers are: crushing syndrome, traumatic brain injury, femur fracture, or lung collapse. Correct answer: crushing syndrome. All 4 of these answers are possibilities, but the one most related to being buried is crushing syndrome. When an extremity is buried for extended periods of time, cell death occurs. If consideration isn't taken when the patient is extricated, toxins can cause renal failure or cardiac arrest. 3 more to go. Your patient is a 55-year-old male who has been impaled through the cheek by a large fishing hook. He is unconscious and has a small amount of bleeding coming from his cheek. The fishing lure is inside his mouth. When caring for this patient, you should. Answers are: trim the lure so it does not obstruct the airway, then leave it in the cheek. Remove the fishing lure. Hold the fishing lure in the patient's mouth to prevent choking, but leave it impaled. Or stabilize the fishing lure and bandage around it. Correct answer: remove the fishing lure. An impaled object should only be removed in 2 cases. The first is when it is impaled through the chest and prevents CPR. The second is when it could cause an airway obstruction. In this case, the fishing lure has the potential to cause an airway obstruction in your unconscious patient and should be removed. Placing gauze on the inside of the cheek also possesses a possible airway obstruction, and trimming the lure will likely cause further damage to the tissue. Next question. You are assessing a 14-year-old female patient who has attempted suicide by lacerating her wrists. The patient has lacerated herself with a scalpel across tension lines. Why is this more concerning than cutting with tension lines? Answers are: scarring is more prevalent when tension lines are cut across. Cutting with tension lines creates a more injurious pattern. The arteries are more apt to be transected across or against tension lines. The laceration will spread wide open when cutting across tension lines. Correct answer? The laceration will spread wide open when cutting across tension lines. The tension lines run horizontally across the wrists, and if the patient cuts parallel with the radius and ulna bones, they will transect the tension lines. These wounds tend to open up more and lead to a greater amount of blood loss, more healing time, and more scarring. In the pre-hospital setting, the blood loss is the most concerning factor. All right, final question. Organs protruding through an open abdominal wound is known as? Answers are evisceration, external thoracic protrusion, sucking abdominal wound, or sucking chest wound. Correct answer, evisceration. Eviscerated organs are ones that protrude through the cavity from which they reside. Thank you for doing this review with me today.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.